Bismillahirrahmanirrahim. Assalamu alaikum. In this video, I'm going to discuss evaluating educational programs and developing professionalism. The learning outcomes are to design and critique evaluation strategies and models for programs and modules, to explain models for developing professional skills, values, and behavior, and to analyze the influence of students, patients, and professional bodies on health professions curricula, and to apply these concepts to health professions education scenarios. So, what is hardest? Designing a good curriculum, knowing whether the curriculum works, developing a professional behavior, balancing stakeholder expectations. So it's quite tricky to decide which is the hardest because it varies from college to college, from schools to school, and from curriculum to curriculum. So it is a debatable thing. So what is the difference between evaluation and assessment? Assessment is how well did the learner perform. So we assess it. It may be a formative assessment or a summative assessment. While on the other hand, evaluation is how well did the educational program perform. When we are evaluating a program, that tells us, did we achieve intended outcomes, and was it relevant? Was the program relevant, and was it implemented as intended? What changed? What should we improve? So these are the multiple questions that arise when we talk about a program evaluation. So we have to answer these questions if we are evaluating an educational program. Let's start using logic model. This is the most commonly used model. It starts with needs, input, activities, outputs, outcomes, and impact. For example, if we talk about communication module, it starts with the need of better communication because there is poor communication within the facility or with patients. There is poor communication, so there is a need for this kind of module. And then comes the input. Input is the simulated patients or the faculty which are providing the learning opportunities or which are conducting the sessions. And there are activities. Activities are simulation, feedback, reflection. All these are part of the activity. And the output is the practice completed. The practice of communication or communicating with a patient is completed. That is the output. And the outcome is improved communication. Improved communication within the OPD or indoor. Better patient experience and safer care is the impact of such kind of communication module. So this is the example showing how the logic model works. So there is an exercise. A medical college introduces a mandatory antimicrobial stewardship course, and you have to write down the input, activity, output, short-term outcome, and long-term impact. And in this way, you are basically evaluating a program, a course, and this evaluation should connect educational activity to intended change. You have to identify what exact change you are expecting after this course, and that in the terms of output, outcome, and impact. So this is an exercise for you. Why to use an evaluation model? Because students like the course, this statement is not enough. Did they learn? Did behavior change? Did practice improve? Did patient outcomes change? These are the questions that need to be answered when we run an educational module or educational course. So evaluation should move beyond satisfaction. There is another model, Kirkpatrick's 4 level. The first level is reaction. Did learners like it? That is the satisfaction survey. Then second level is learning. Did they learn? And we can assess learning by MCQ, by OSCE, by TOEFL. Learning has 3 domains. Learning has the knowledge, attitude, and skills domain. In this case, we can assess skills through OSV or OSP or OST, And we can assess the cognitive domain through MCQs, SCQs, even through OSCE, OSPE. And we can also assess the behavior or the attitude while taking the vivas or short case, long case. So we can assess the learning at the in the second level. The third is behavior. Did they apply it? So this is workplace observation. So we need time, we need to give them time to apply it and then check whether they have applied properly or not. Then comes the result. Did it make a difference? Like patient and quality improvement outcomes improved or not? Or this course has changed the overall satisfaction of patients, or you can say the workplace environment changed or quality outcomes changed. So that these are the results. So in behavior, in workplace observation, you can use different methods, direct and indirect observation methods. Kirkpatrick model is being critiqued because higher level does not automatically mean better. Satisfaction does not guarantee learning, and learning does not guarantee behavior change. External factors, they do influence the result. Level 4 attribution can be difficult. For example, in 95% loved the course, but ASCII scores did not improve. And it was successful, yes or no, it depends. So it's quite tricky to run a Kirkpatrick model. Now, the next model is SIP evaluation model, in which C is for context, I for input, P for process, and P for product. This is a valuable model when we are using the program evaluation for decision making, and comparing the before and after model, or before and after comparison is there. So context is what problem are we trying to solve. Input shows that what resources and strategies are available, and process shows that is the program implemented properly or not, and the product, what did the program achieve. So when we are sitting on the side of a program and looking at the program from input, processes, and output is the product, then we are in a better position to comment where the flaws lies, or how through decision making we can improve it or not. So when we compare both, Kirkpatrick is strongly outcome or learner focused and is useful for training evaluation, while SIP is a broader program or systems perspective, or in which the strong emphasis is on context, input, and processes. Which model would you choose before launching a new curriculum, and why? So the answer could be, for training evaluation, I would choose Kirkpatrick. For program evaluation or evaluation of curriculum, implementation of a curriculum, then I will go for SIP. It's better to plan evaluation backward. What decision will the evaluation inform? What evidence do we need? How will we collect it? How will we interpret it? And what action will we take? So evaluation means evidence plus interpretation plus decision making. All these things collectively, they make the evaluation. And in evaluation, we are actually, ideally we should go backward. So when we use multiple sources of evidence, in that case, we have the option of going for triangulation. For example, we can have data source triangulation or data or methodological triangulation. In this case, we have different data sources from students, from faculty, from patients, and we can have different methods of data collection as well, like OSPE, OSCE, survey, in-depth interview, focus group discussion, etc. And then we conclude. For example, the conclusion is that partially the curriculum or program is partially effective, so we need to redefine the module. In that case, this conclusion is based on the triangulation, and that this triangulation is the key feature, or very important when we go for multiple sources of evidence and multi-method study. So there is an exercise that a hospital introduces code blue training. So what would you measure in code blue training? You can measure knowledge, you can measure simulation, teamwork, response time, confidence, protocol adherence, clinical outcomes, and retention. So there are multiple things that we can measure, multiple attributes that we can measure, and with different outcomes require different methods. This need to be kept in mind, that if we are going for different outcomes, we can have different method. For example, in protocol adherence or in clinical outcome, we can have quantitative or qualitative or mixed method approach to collect the data. In evaluation methods, we have, again, I have just mentioned that we have three options: quantitative data, qualitative methods, and the data will be qualitative, and the mixed method using both quantitative and qualitative. In quantitative, we have MCQs, OSCE scores, pre-post test, surveys, performance indicators, patient outcomes. These can be measured quantitatively, while in qualitative means a textual data is generated, like in interviews, focus group discussion, reflective narratives, observation, or open-ended feedback. While in mixed methods, numbers tell what happened and qualitative evidence tells or explains why. So if we are interested to determine what and as well as why, then we can move to mixed method. Professionalism is more than knowledge. Professional competence combines knowledge and skills and values and attitudes plus professional behavior. So knowledge and skills plus values and attitude plus professional behavior. This combination gives professionalism. A learner may know the correct behavior but fail to demonstrate it. So professionalism includes demonstration as well. In Miller's pyramid, you know that knows means the knowledge, knows how, application of that knowledge shows how, demonstration does performance in real practice or real world. For example, breaking a bad news. MCQ can test the knowledge. The case discussion can help build up the application. The simulated patient shows how, it's the demonstration, and the does is real patient encounter and breaking bad news in real scenario, that is the does portion of Miller pyramid. Interactive, which level? For example, if we talk about take an example of informed consent, it can be measured with MCQs to cover the nose and shows how consent with simulated patient, consistent consent with real patient is does. So what is missing between knowledge and authentic performance? That is the question. Okay, in knowledge and authentic performance, that is the drill, the practice, the shows how is missing. So shows how is very important to become an authentic performer or an expert. Treffer's model of skill development, it starts with novice, advanced beginner, competent, proficient, and expert. In medical schools, we are going for competency-based curriculum because we want a competent doctor to be produced. But in postgraduate, we need competent postgraduate graduates, or you can say the consultant, but we need them to be proficient as well. So proficiency is important for postgraduate training, and then they convert into expert with experience, practice, feedback, and reflection. Experience and practice, it will take time. So usually senior registrars, they also work, they have the degree, post graduation is done, but they still work under the expert guidance or supervision of the senior person. So what supervision does a novice need compared with an expert? That a novice needs a full directed learning or supervision, complete supervision or mentorship, you can say. Developing professional values. Values are not developed effectively through lectures alone. We need role modeling, experiential learning, reflection, and feedback. These are the four things that develop the professional values. And what do seniors actually do? What did I do and why? How can I improve? If one asks these kind of questions from our own self, we find that the role modeling, reflection, experiential learning, and feedback from others. That helps a lot. Reflection is about our own opinion or perception about our own action. For example, it can be reflection during action or reflection on action. And while feedback is from other person, give me feedback on my action, give me feedback, my teachers can give me feedback on my lecture. So it can be like that. The hidden curriculum, the formal curriculum is respect every patient, while hidden curriculum, it makes students learn that seniors dismiss patients' concerns. So learners observe behavior as well as hear messages. So culture teaches louder than curriculum. That culture is the hidden curriculum. There is another example of a hidden curriculum that a student is publicly criticized for arriving late. Later, the consultant arrives late and says senior people have different responsibilities. So, what kind of professional lesson the student has learned? Hierarchy, double standards, accountability, and power dynamics. All these things, they make the hidden curriculum more powerful than the taught curriculum. Role modeling. Faculty model says that respect, integrity, accountability, empathy, teamwork, patient-centeredness, and ethical decision making. These are very important. So they are role model. They role model themselves while they give respect to others. They show integrity. They show accountability, punctuality, regularity. They show empathy, patient-centeredness, and ethical decision making, following the basic ethical principles of privacy, confidentiality, maleficence, and non-maleficence and beneficence. So you can think of one teacher who influenced your professional behavior, and what did they do? From intention to practice, we teach, demonstrate, practice, observe, feedback, reflect, re-practice, assess. So professional behavior requires repeated reinforcement, not a single lecture. Who owns the curriculum? Students, patients, faculty, professional bodies, regulators, employers of the hospitals, government, community, alumni, they all are the stakeholders. They all contribute, but influence and responsibilities differ as well. So in a curriculum, students, they work as the stakeholders in course evaluation, student representation, curriculum committees, focus group. They can co-design curriculum. They can work as peer teaching and learning analytics. The balance is that students' needs plus professional standards plus societal needs plus patient needs plus evidence. This will make a successful evidence informed curriculum, because we are catering the needs of all the stakeholders as well as the evidence. So should student decide everything they want to learn? No, that is not true. That should not be true. Uh, this mix is important. This will keep the balance. Patients as curriculum stakeholders, patients advisory group, interviews, narrative, feedback, they can co-design, simulated patients and community representatives. Healthcare education ultimately exists for better health outcomes and better patient care. Patient-centered curriculum asks, what does the patient need from the doctor? But in our setting, the curricula are not patient-centered. They are competency-based curricula or outcome-based curricula in which patient-centeredness is there. But entirely patient-centered curricula, they don't exist in this world of this part of the world. Professional bodies like PMDC, CPSP, HEC, specialty societies, accreditation organizations, they have influence like community standards, competency standards, curriculum requirement, assessment, accreditation, professional expectation, and continued professional development. These are the things they are influencing. So these bodies they have influence, and here the issue is of standardization versus local relevance. So we have to keep a balance between local relevance and the standard practices. So stakeholder conflict case. Students, they are more exam focused. They need more exam focused training. Faculty, they always complain of limited resources. Professional bodies, they say competencies must be covered. All competencies must be covered. and patients, they ask for better communication skills. Hospital, the graduates, they want their graduates, they need to manage real clinical problems. They want their graduates to manage real clinical problems. And the question is, whose voice should dominate? So here comes the stakeholder power interest matrix. High power, high interest. Like if some stakeholder, they have high power and they have high interest, they should manage the curriculum closely. But those who have high power and low interest, they should be kept satisfied because they don't have that much interest. Low power and high interest, keep informed, keep involved them. If they have low, if the one, any stakeholder has low power and low interest, just keep them as to monitor the curriculum, but not engaging them or involving them. The activities like place students, patient, regulator, faculty, hospital administration, government, according to this stakeholder power interest matrix. So design a curricula on patient safety and quality improvement, and you can decide the learning outcomes, patient contribution, professional body requirements, faculty contribution, evaluation plan. Each of your group can share one recommendation regarding all these. So when you design a curricula or a course curricula, then you should look into all these things, and you should make it a write-up on that. So bringing it all together, curriculum development is a continuous process, not a one-time event. There is another communication curriculum case. After 1 year, you got 90% satisfaction. OSCE scores improve. Faculty report persistent communication problems, and patients report little improvement. The graduates report lack of workplace reinforcement. So is the curriculum successful? What evidence is missing? Actually, this curriculum is lacking the implementation, or you can say real world applicability, and the real world change. You can apply today's models. Kirkpatrick, what happened at level 1 to 4 on this example. You can apply Miller, at what level are we missing? Are we assessing the competence? And hidden curriculum, what is happening in the workplace? Stakeholders, whose evidence are we missing? So in this example that we just discussed of the curriculum, communication curriculum, we can apply all these and answer these questions. Final curriculum committee decision: if the committee decide to continue or modify or discontinue, they need to explain why they support. In the support of their decision, they need to give evidence. Evidence based rather than opinion based decision making should be done. So evidence is important in this case. Now take home messages. Evaluation is not simply collecting learner satisfaction. Good evaluation begins with clear decisions and outcomes. Professionalism develops through modeling, experience, feedback, and reflection. Hidden curriculum can be more powerful than the formal curriculum. Students and patients can be curriculum partners. Professional bodies provide standards, but curricula must remain responsive to local needs. No single stakeholder should automatically control the curriculum. So the last thing is, one concept you have learned or I learned, one concept I will apply, one question I still have. So you can write it down, give it in the comment section, and I will try to answer in my next video.